I'm going ahead just for a second. Just reflect on these couple of pictures just for a minute on it, and we will come back to them at a certain point there. Okay. Most of you guys have sat through workshops where they talk about this exquisite design of an infant, a full-term infant, to be able to suck, swallow, breathe, all this whole thing and coordinate it. Through your work, through your experiences, you also run into the premature infant who has had that disrailed. They are not the same. We're going to talk about the physiology. I'll go through it a bit. But I want to go take that next step in terms of it's not just the physiology, it's that neurological processing, the infant learning to learn how to learn, to create a motor plan in their head so that they can volitionally, at a certain point, namely after birth is what it comes down to, be able to generate a meaningful oral movement to start to process the food on it. And we're going to go through talking about mainly motor planning on top of the physiology. It's not that we really overlook this whole learning of a motor plan. It's more that science hasn't really figured it out yet. We don't know, even for after birth, how we learn a motor plan in particular. We take in sensory input. We take in visual, auditory, all these things, set up the wiring in our brain to be able to learn a task, anywhere from learning to play the piano, speech, and in what we'll go through later, as to eating more complex food, has to develop a motor plan that is able to organize the mouth, organize the tongue, organize the jaw, organize the timing of the swallow, and move from there. For the infant in utero on it, it's primarily reflexive on it from that side. They are in a system where they have the amniotic fluid coming in. By 15 weeks, 15 to 17 weeks, the aerodigestive system is formed. 17 weeks, you are getting to the point where they've observed swallowing going on. That swallow sets up the whole process that goes on through age 2 years plus in terms of getting the complex system to be able to handle the food. Disruptions at any point in there, neurological, syndromes, premature birth, all will change that motor learning pattern or the ability to learn the motor pattern in a consistent way. That's going to impact us. Now let's see if I got the right way. This quote is from Catherine Shaker. For those who are therapists on it, working with kids from prematurity and in the NICU, she is basically way up there on it. Everyone has probably taken a course from her. This quote on it, and it is actually all one long paragraph. I split it up so it's a little easier to read on it. This quote is from a recent blog that she is still actively involved in the training of. But let's go through it here. The infant born prematurely, let's say at 23 weeks, has had only 6 weeks of motor learning for the aerodigestive system in utero prior to a premature delivery. And yet, this infant will be asked to PO feed long before they reach 40 weeks on it. The key point here, again, if they are developing their aerodigestive system 15 to 17 weeks, they're starting to swallow at 17. If they're born at 23, they've only had 6 weeks of practice. A full-term infant, 20 weeks plus of practice. 20 weeks plus of practice that is not only just in a static system, but 20 weeks of practice with a changing system, changing by growth, changing by their neurological system growing and developing. So they're getting all this practice to set themselves up for the one missing link once they're born on it. They're able to suck, they're able to swallow on it. They have to learn to breathe. Again, a disruption earlier is going to significantly change that pattern and the ability to manage it successfully. Second paragraph there, even at 40 weeks, the preterm infant is not like a full-term infant. They never will be. The structural relationships will be different than those in the full-term healthy newborn when the former preemie reaches 40 weeks. And you looked at those two pictures, that's why I went to it. You are not going to have the same system on it. Even though One, you're not going to have sucking pads. You're not going to have the ability to control your body at the same level. These underpinnings, these lack of the supports on it, excuse me, on it, including they did not experience the physiological flexion in utero and lacked the motor learning, that practice and associated system development required for coordinated feeding. So what are the differences? The motor, the flexion, those last few weeks, that growth pattern, should have got water, sorry. Those last few weeks on it, the growth pattern, bringing them into flexion, being able to develop, one, bringing their hands forward, all those aspects are going to be significant in the long term. They're going to be significant after birth in terms of further development. The physiological factors, the mandible, again with that flexion, comes down toward the chin, toward the chest on it. You can swallow with way back. Try to put your head way back and swallow. And then also now bring your chin forward. You can feel the difference. It's a little bit shorter excursion on it, but the premature infant born 23, 25 weeks is not going to experience that. One of the aspects that that's going to change is as they grow, as they get bigger on it, that step in terms of bringing their chin down toward their mandible and being able to get that suction going is going to set them up for the volitional control, because it's, wait a minute, I got to pull that amniotic fluid back and it goes back there. They're learning how to learn to do a motor plan that will support them when they are taking the bottle or breast on it. Sucking pads, why are those important? One, the liquid doesn't have any place to go but back. The sucking pads also set up a situation where it presses into the tongue, helps set up the curved groove that when we're assessing all we're looking for on it, which indeed, because of the reflexive action, is able to help with the latch on it. Therefore, they're being able to create suction, be able to create the closure, and become more efficient swallowers, or suck swallow at that point. The tongue, with that last burst of growth toward delivery on it, is basically filling the oral cavity. Again, there's not that much place for it to go. Think of that picture that came up with the premature infant. Extension, open mouth on it. There's not sucking pads. They're not going to be able to have that whole system delivering that liquid back. The preterm. Basically, we might as well go with what don't they have on it from that side. That last growth spurt is when the sucking pads come in, 36 weeks, somewhere in that range. You're not getting those sucking pads. You're not helping groove that deal. The extensions are, the extremities are in extension. What significance does that have? They are having to work. They are having to bring themselves into flexion. They have not had this experience of their hands coming to their mouth, which sets up the sucking action on it, which is their practice. There's that motor plan that the premature infant is not going to have because their arms are not getting consistently to their mouth. They're not getting that 20 weeks of practice. They're not getting those last few weeks of pulling it together and starting the sucking rather than just the reflexive swallow. The jerky, organized movements, and the poor state control. Obviously, those of you who work with preemies on it, that's a big factor. In terms of motor learning, they simply are going to get too jittery. They're going to lose state control. They're going to lose it control, basically, and they're not going to get the practice, or it's going to be very short time. If you think about the child in utero, they're getting consistent practice. They are getting ongoing 24 hours a day at different times with the swallow and the time frames when they're moving and figuring it out from there. And that's also probably a big factor that we don't completely know on it from there how it works. Every day as this child gains weight, gains size, there is some change in their physiological structures that they are adapting to. They are altering their motor plan to be able to continue to change and learn how to learn to make a motor plan that changes. A premature child at birth, this stopped to a large extent because they're in the hands of the angels to basically go, you guys saving their life on it, and they're not developing in the sense of going this positive, sucking, swallowing, etc. They're having all sorts of interventions to try to move them forward to be able to do that. This slide is from Chantal Lau on it, and you can read it on it yourself. The biggest factor here is it's basically a summary of the motor plans change. They are not in sync. Everything is disrupted. This kid is basically going, I am choosing breathing over swallowing at this point in time, so they are not working to coordinate it. This puts everything off in terms of the cycle on it. And if indeed you are fighting, there are no sucking pads, you are going to have a harder time figuring out where your tongue goes in space. How do you then organize it? How do you latch, etc. on it? And that's going to be completely different from the reflexive swallow. But you're also, in long term, losing the chance of practicing. This is what I'm going to have to do when I need to form a bolus, pull it together, and move it back. Why is that critical? This is a really interesting slide on it, these next two. On it, infants breathe at a rate of about 40 to 60 breaths per minute, 1.5 to 1 breath per second. Chantal Lau's research has shown that immature pharyngeal swallow lasts up to 3/4 of a second. You don't have a lot of time to stop and exchange it once you come out of that womb in terms of going, this is how I need to coordinate my breathing with the swallow and suck on it. There is very minimal time frame. This sets you up for the risk of aspiration, the coughing, the gagging, and all the other stuff that doesn't look as, again, it's reflective of there. During feeding, and this one you guys, I'm sure, with those handling the babies, ventilation patterns decrease, exhalation increases. Those patterns change in breathing and the exchange as they mature, get more control. If you're back to a premature infant having lost all these supports on it, that's going to set you up for the fact of going, ooh, it's going to take longer to establish this motor plan. Extremely preterm infants on it tend to be sufficient feeders. We do a good job on it. Family does a good job. The nursing does a good job in helping them provide the supports. All those supports that a full-term infant, that exquisite design, the sucking pads, the tongue being pulled into a groove on it, the limited hyoid movement that's necessary on it, all those are supports that set up learning of the motor plan. The feeder, after this child is born, have to provide. So what do we provide? Dynamic positioning on it. We are giving them the positioning that brings them into flexion, giving them a chance to most effectively control their body so they can set up a suck-swallow pattern. It's not going to happen easily. It's not going to happen quick. These kids have been set way back. They have not had 20 plus weeks of practice on it from there. We have to give them the supports to be able to set up ability to learn the motor plan. And if we don't, when they don't learn that motor plan, how are they going to take the next step up when it becomes volitional on it? They're not going to have that experience to be able to move forward and say, oh, I need to get my jaw in line. Well, the jaw comes into control at about 3 months of age after on that side. You start to get control of the jaw first. Getting control of the jaw really is important in the sense of going, as this child grows, they can control the jaw, which means they can control the tongue. The oral space, as they physiologically get taller and grow, gets bigger. It is harder for a kid to coordinate the suck-swallow when they get to that 3 to 6 months of age because of that size and growth. A premature infant is still, well, wait a minute, I got to still get control of this whole thing and coordinate the breathing. And they also physiologically don't have the ability to pull it together without our supports. So therefore, they're at a loss or they're further behind at that point. That sets up feeding problems down the line. In that second paragraph, the most significant aspect, before I turn it over to Janice, is the infants at discharge reported to have feeding and swallowing problems. 19 to 20% to 80% of these kids have some issues. The motor learning, the motor plan is not there. they're having difficulty organizing it, and it sets up different loads for different loads for learning the motor plans to move forward in the complexity. This is just a quick slide that sets up what happens next on it. As you can see, the infant on it from that one, tongue takes up most of the space. They don't have to work very hard to formulate the bolus. It's only going to go one direction, and particularly for those very young infants who still have the sucking pads before they merge into oral cavity size. You can go pretty much straight back on it. There's a chance for them to have support to learn their motor plan, to set up what happens in the toddler. You notice there is more space in the oral cavity. This is when sounds start to come in too. There's place for the tongue to move. You're getting control of the respiration and better can deal, again, volitional control. And then they can move their tongue, and they're learning how to, again, motor plan there. That sets up the tongue movements necessary for bolus formulation. That is critical for transitioning into solid foods on it from that side. So again, this whole pattern is about neurological and the physiological. So often we just look at the physiological, but we have to be the ones supporting all that learning that's going to go on to help them move forward.
Okay, Paul and I are a team. Some of you know this, a lot of you maybe know this. Paul is clearly very good at looking at some of the very specific physiological variations that we see in the suck, swallow, breathe synchrony early on, and then the kids leave the unit. We're involved as OTs a little bit in feeding in some units, less and less so. It's the speech pathologists who try to get things going orally and are supporting the caregivers in getting to that okay but not great stage of feeding that a lot of the kids leave the unit at. And it's not uncommon for us then to get a post-discharge referral with a request to address some of these concerns. Sometimes the referral comes from Dr. Needleman, who will describe a child who's maybe failing to thrive or whose parents indicate that they'll only eat when they're asleep or drowsy. We can only get them to eat if they're asleep or nearly asleep. There's a lot of fatigue or endurance issues impacting. Some of these kids leave the unit, I think more so lately, with a tube, sometimes a gastrostomy tube, sometimes an NG tube. The parents are very motivated to not use the tube. And sometimes a consequence of them choosing not to use the tube any more than they absolutely have to is that the child isn't consuming enough and is wearing out maybe before they can get enough in orally, and there just is that gap between what the parents are hoping to accomplish and what the child can manage. GERD and MSPI certainly impacts a child's acceptance of the feeding process if there's pain associated, et cetera. And then our ability to determine whether or not there's oral motor involvement that's interfering with feeding gets better over time. So we can see that discoordination that's just a function of lack of practice and an immature system as the kids leave the unit and they're first being cared for in the home. But when those oral structures do get bigger and there's more space for them to have to manage the food and liquid within, it gets harder. And if you've got a system with clear evidence of neuromotor damage, I guess I want to say neuromotor is the clinical picture that the kids have, but if we have a system that we are watching because we know that there was an IVH, an interventricular hemorrhage, or there's evidence of PVL, or there's some hard signs that they were discharged from the unit with, we start to see oral motor dysfunction, and we have to adapt more and more the feeding process. So certainly with OT, we see a lot of kids who just don't want to transition to pureed food or any kind of solid. There's sensory issues that we deal with, et cetera. So those are the common referral concerns. It's complicated. And I mean, it gets more complicated over time because that first year, there's so many factors that play in. This is a diagram that was put together probably 15, 16 years ago. We're dating ourselves. Paul and I have worked together for over 30 years. 30 years. We're really not that old. But I mean, all of these factors, the goal is food intake, right? We want the kids to eat, but Dr. Needleman's point that it's not just about the baby is really, really significant, because there's so many parental characteristics or caregiver characteristics that matter as much or more. We run into mommies who are so heck bent, I gotta watch what I say, against using the tube, the G tube or the NG tube, that they really compromise their child's growth and development. It's hard to understand in our position why you would make some of the choices that you make. Some caregivers have a sense that they need to make decisions very early about the quality of the food their child is offered, and if they're told you've got to jack up the calorie content, you've got to jack up the calorie density of the food you're being offered, we run into mommies who resist that, because, you know, putting butter on everything, that's just wrong, right, from a health perspective, if you're 62. But these babies we got to feed, we're feeding their brains early on, and so we see lots of interesting things, and sometimes the mommy's mental health or ability to manage the stress that goes with parenting a premature infant. Sometimes it's just something as simple as helping them set up the feeding environment. Sometimes it's all about the way they're handling kids. I'm constantly, well, we all have very different bodies, right? With a young baby, I often wish I was fleshier up here because it'd be more comfortable for the baby. But some moms just truly are uncomfortable modifying their physical position in order to support the baby the way the baby needs to be supported. Sometimes that's the kind of thing we do. So I think this slide is just a good overview of the sorts of things that we're looking at all the time with every baby at every age whenever they come to us. One of the factors, and these are all embedded in that previous slide, but motivation to eat is something that we run into as an initial question. A lot of the kids that we see have no sense of the hunger satiety cycle. They have been tube fed, sometimes a continuous drip kind of thing over time. This is especially the gastroschisis babies who don't have an opportunity to eat orally as soon as some of the other kids. The tube feedings take up all their time. They never learn what hunger is, or that feeding has a relationship with satisfying a hunger. So those kinds of things. And then, of course, there's physiological factors that play into that, too. We run into kids who are refusing to eat, and this is very, very difficult for caregivers. And I don't want anything about this slide or the discussion going forward to implicate what we know nursing has to do in the unit to support the life that we want these babies to leave the unit with. There's so many interventions that involve invasion, for a lack of a better word, to the oral mechanism. There's so many things that we have to do as caregivers in the unit that are aggressive, for lack of a better word. It's not intentionally aggressive, it's a life-saving aggression. And aggression's even the wrong word, I'm just not coming up with the right one right now. But there's conditioning to that. You know, the kids learn to be a little bit like on guard. We run into kids who refuse to eat, and so this is just a diagram that I like because it talks about things that make a child anxious or fearful and how they relate it to eating or feeding later on. So in this case, reflux, aspiration, just the discomfort of not knowing if you can handle the food orally, you're going to get anxious. So that anything that they also associate with that threat, it can be as simple as being in the kitchen and knowing that mom's getting food ready. Your sense of smell might trip anxiety. I just don't want anything to do with this. Setting the table, looking at the utensils. So when we do pre-feeding evaluations for children who are being considered for transplant, usually these are kids with liver small bowel issues, post-gastroschisis, post-gut problems in general. We'll encourage those moms, the family, even if they're NPO, even if these kids aren't able to eat orally at all, and probably won't for the next year or 2 or 3, or until they have, transplant surgery. We'll encourage them to involve them in mealtime routines. Just the social environment of mealtimes is supposed to be positive. It's supposed to be friendly. It's supposed to be like a happy family time, right? So we want the kids to be sitting on the island in the kitchen when mom's cooking. We want them to be around food. We want them to see food. Heck, we want them to play with food. We want them to watch their caregivers and siblings enjoy food so that they too are interested in being part of that social dynamic. So that's just one way we try to work around it. But again, I'm not saying that anything that happens in the unit or to save these kids' lives or to keep them alive and healthy should be stopped. You can't. You just have to be aware of the fact that any positive dynamic you can create around those same things that kids might associate might have some value. Feeding problems that begin with a physiological underpinning, this is from the Thor article, later develop into a behavior problem. I think that's kind of a no-brainer, but this just tells us that just because we fix the GERD or because we fix the MSPI or they outgrow the MSPI, it doesn't mean that they're going to suddenly embrace eating. Kids, remember, they associate. It's just not that simple. Go back to the point that it's complicated. And then some of you who are maybe high-strung like I am can recognize that if you're really, really anxious, it's hard to eat sometimes. I mean, it has to be a pretty high level of anxiety at this point in my life, but it's a physiological reality that if you're in sympathetic arousal, there are changes in the way your system can handle and manage food. And I think we forget this. I think parents, we have to remind parents that anxiety for kids is just as real as it is for us. And we have to make them recognize that their anxiety is something the kids play off of too. So again, it's not just about the baby. Dr. Needleman's point was very well made, and we just keep coming back to that. It's not just about the baby ever. And then there's this other element of behavior that sometimes behavior works. You know, sometimes behavior is exactly what the kid needs to do to get away from what they don't want. And a lot of what we do with a family is to help them recognize how their reaction to the child's refusal or the dynamic that they have going on. Sometimes the kids are just waiting for their parents to blow up. They really like it. Or they've learned that if they act out, then they get away from what they don't want. So, and then sometimes the kids' behavior has sort of a sensory, like, we like this. Now those are usually lower functioning kids. There's usually a big picture that's very different in that situation. But behavior is something that, I mean, we're speech therapists and OTs. We have to understand behavior and how that's impacting everything. So these are just some points that were made and the references that we include at the end of this. I like the statement that it's the interactions between the caregiver and infant during feedings that both promote and constrain. The caregiver has a lot of power in the feeding dynamic, a lot of power, and sometimes the best that we can do is help to modify some of the things that they might be doing to negate a positive outcome or make it difficult for the child to continue eating. Parents do a lot of I like these terms, co-constructed activities. The caregivers are always negotiating with their child about feeding. Parents help co-regulate it. They decide, we need to do this. This is how much they need to take in. They don't decide. The pediatrician and the nutritionist helps with them. But so they have a goal, and they need to do X, Y, and Z to get to that goal. They're very motivated to do what they need to do to support their child's growth and development, but sometimes they can't see the forest for the trees for what they might be doing to interrupt success in the direction that they want to go. So we do, I'd say 75% of what we do is support the feeder. We try to help the feeder understand things from our perspective. Often, I think the sessions that I enjoy the most are sessions where the family comes in with family members who are putting a lot of pressure on them. I can really recall, and this is probably several years ago, but Paul and I met with a family whose infant or young daughter under a year of age, maybe a little over a year of age, was eventually diagnosed with, help me, Paul, it's real severe autism, the disorder where they don't use their hands.
I'm older than you.
Yeah, great. Rets, thank you, jeepers. That used to fall in the spectrum, and that's what made me stop and just fall apart there. The young lady, she just wasn't progressing to purees, and when we watched her eat, we had never seen such disordered oral management. It was remarkably disorganized and just puzzling with a capital P. And the family was getting all kinds of pressure. Give the kid to me, she'll eat for me, you know, from grandma. You can hear that. You can hear all kinds of caregivers saying, you're just not taking charge. You're not being a good mom. And I mean, those parents were reading her like a book and doing exactly the right thing. So in that situation, we got to affirm the parents' gut feeling that something was not right. And they were on the way to see the geneticist, who eventually diagnosed something that nobody wants diagnosed in a friend or family member ever. But that was one of my favorite sessions. I still remember it. I bet it was 5 years ago that, we saw that little girl eat, and we said, oh, you are absolutely doing what you need to do. Don't push. This is the limit. This is the limit. So that's a lot what we do, is we help them identify the priority and hopefully move in that direction. Accommodations we often suggest, and that's a lot of what we do. We just offer accommodations, or this is your priority right now. Make sure that you keep food or liquid within this texture, depending on what we see the child manage. Sometimes it's a swallow study that helps us make that decision. Sometimes we can make that decision clinically. Presentation rate can be a big deal. Parents are sometimes told you have 20 minutes to get the child fed before endurance takes over, but not necessarily jacking up the rate of presentation is going to be a good idea. So sometimes they're getting ambiguous. You don't have much time. Endurance is an issue, but they can only manage it at this rate, so you need to be careful. Bite size, sometimes they're just giving way too much. Sometimes they're not giving enough because the child needs more to be able to perceive it. Sometimes we can help them, just in talking with them, we learn that the child has a tendency or is drawn to really strong tastes. I mean, we see 14, 15-month-olds who love barbecue sauce and salsa. And that's unusual. But that tells us that maybe a lot of kids stuff their mouths. They cram their mouth way full before they even seem to perceive that it needs to be managed. So some of those clinical things that we see give us a sense for what the child might be perceiving. We can't ever really know, but we start to hypothesize and try to support from a perception that we might share. And I don't have any more. See, I can race through anything, I guess, huh? Do you have questions? Did I talk too fast? Oh.
I was just curious about what was presented earlier about how your development in utero and how when you're born at however many weeks, you miss out on that development to help organize and be ready for feedings. So in the NICU, should we not be feeding at 32 weeks and delaying oral feeding to help them better organize and meet those milestones? Should we be looking at other things before we progress them to feeding?
Isn't that one of the debates we get going in terms of when do you start? When is the best time?
And then we put it down to 32, and I think the talk is back now to 34. It seems like it's something.
Oh, don't ask me that.
I do feel like in that regard, if you are so carefully respecting what that baby is telling you, that would probably help them to have some of those experiences earlier than others. So some babies at 32 weeks could potentially benefit from those exposures of nipple feeding if we so carefully respect what they're telling us with their cues. and then ending feedings when they're done, not feeding them if they're not showing us all of those cueings, you know, and then other babies I think could really benefit from not even initiating any type of feeding until 36 weeks. So that's where I think it just comes back to really
Well, and
watching
how
them.
many babies do we hear they just won't wake up to eat?
Right.
They just won't wake up, and that's the cue-based feeding that you're talking about. It's all about reading the baby, and are they really cueing to eat, or are we deciding that they need to eat?
Yeah, I think that, again, it comes back to that question, that 36, 32, you know, whatever we're looking at. But I do think you have to go with the baby, because if you go with the fact, if we break it back down to how are they learning to learn, we're providing the supports. We basically are having to give everything that sets up a successful feed. If it doesn't work when we give as many supports as we can, and those aren't perfect, there's no doubt about it, but we basically have to follow the child. I mean, I think that's, when I was putting that together and let's focus toward the motor learning aspect on it, it was like going, this is justification why we need to go cue-based. We need to go with reading that infant, because something in that pattern is telling us that it is not there yet. We need to then take a serious look in terms of going, what supports can we provide? And that becomes the intervention. That becomes moving them forward. But we also need, I think that statement is they're not going to catch up. They're not going to get to suddenly 36 and have sucking pads, have a tongue that is ready to establish that. So we basically have to provide those supports to help them get back onto the path, or get onto the path to learn it. And that's the structured part that really gets confounded by an infant who has respiratory problems. They can't settle in. They can't get that support on it. So we're basically dealing with how we deal with the respiratory on top of the positioning we're doing, on top of the flow rates, et cetera, on it from there. But
I think, are you asking, would we benefit more of our babies by waiting till 34 weeks than we?
you want me to answer that one? Let's see. Call Chantel Law, please, from that side. That would be I think that's where we're stuck. And we don't know. That's the worst part about it. We are talking about in utero being all reflexive on it with a lot of practice. The child's born. We're adding that one last component. You got to breathe and suck. Well, wait a minute. You don't have the suck yet, or it's not well organized. How do we provide that organization? That's the struggle. And then the fact is we're running into state issues, we're running into fatigue issues, we're running into cranky kids on it from that, inconsistent feeders in terms of the parents being there, not being there, et cetera. All of those go. I wish there was an answer, but it really comes down to the kid. I guess until we understand better neurologically what is the support levels we need, then we're sort of stuck on it from that side. Basically trusting our own guts, having really good communications all the way from here's the medical side, now here's the therapeutic side. Somewhere in the middle, we have to read the kid to be able to help move them forward. So, you got a question way back? I'm dodging them. That's why I'm asking you now.
I was just wondering, because I'm supporting teachers that are, in the field working, or people that are working with families, and so do you have recommendations for if they see something that they're concerned about in terms of feeding? What would you recommend in terms of them accessing additional support? So you talked a little bit about are you guys providing services right now that they could access, or what would you recommend?
How do you want to answer that? She's going to retire. I'm moved away more from the NICU, so therefore we are questionable in it. But no.
I assume you're talking about people who are getting EDN support?
Sure, or up to like age 5, but thinking specifically about that person.
Yeah. I feel like I'm being baited a little bit here. There are several service providers that provide feeding support. Children's Hospital has an aerodigestive team, and they provide outpatient therapies from both speech and OT. Depending on the age and the nature of the problem, I think, is which discipline will pick it up. Monroe Meyer has speech pathologists who provide direct treatment in feeding, and OTs who can support. We tend to pick up clinically when kids are moving more towards self-feeding or solids come into play. So because there's such a sensory element sometimes to the solid. But yeah, PTs, OTs, speech, and then I think there's a pediatric feeding disorders clinic at MMI that has more of an ABA approach. Our bias is participation and more cue-based and more positive, and so we aren't part of that clinic at all. I'm sorry? I think most of theirs is with cleft lip palate kind of interventions, and I'm not aware that they have a team. Well, CHI has a team. Lisa Jordan is a occupational therapist who has some specialty skills in feeding. She works through Lakeside or Creighton. Oh, Lisa!
I told her that's why she wanted to stand up.
I know. Okay. Lisa does outpatient. How do they get to you? It's the Creighton Clinic, right? The Creighton Pediatric Clinic?
Mm-hmm.
Yeah. Sorry, thank God I mentioned that. That would have been bad.
I was going to offer her to stand up from that side. From anybody else? I mean, equal time.
What do you guys think about the end trainer and how that is working in NICUs, or do you know much about it? I've seen it just done a couple times. We're not using it here, but
The tiptoeing through the whole procedural aspect has been slow on it from that side. Amy Nordness is running the grant and the research project on it. It's still such a slow start, but she's very comfortable with what it does and what it can do. It's getting another restart in terms of looking for a specific population, this one, and I'm not even going to, again, I told you I'm moving away from the NICU to that extent, but
I think she's been really underwhelmed with the outcomes related to.
I don't know if not necessarily outcomes, but again, worth the process of getting the kids, getting the logistical deal. Who's running it? Is it nursing? Is it speech? Is it that whole deal? And this, not protectives, that's not the right word. It's just going territorial to time to et cetera. What we run into in a NICU at all cases. So,
Dosing.
yeah, the dosing is going to be the deal. It's still active on it. Probably the best bet is call Amy on it from that side, because it's worth talking about on it from that side. Anybody else? Lunchtime.
Are you impressed that we quit on time?